I welcome everyone to Denver CVI 2019. We're on a panel here. I'm Chris Malasry, cardiac surgery from Northwestern, Molly Zerlip, interventional cardiology from Dallas. We've got Paul Saraja and Adam Greenbaum right now.
Samir
and Samir just walked up to the table. Cleveland, why don't you go ahead and introduce yourself and your case?
All right, thank you. Thank you so much for having us. Thank you, Paul, Manus, Maddie, and Subhash for the invitation for us. I have heard that the Congress has been a very great success so far. So I'm Guilherme Attizzani, interventional cardiologist. Dr. Baeza, Christian Baeza,
heart surgeon.
And Chinedu, interventional fellow.
We have as well Phil with us, Maria and Nick. Great team. We have Steve as well in the echo with us here today. So we're gonna have Chinedu introduce our case here now. Please go ahead, Chinedu.
Next. So our patient here is a 78-year-old woman who's had multiple hospital admissions for shortness of breath, and in the last admission was found to have severe AS. She's NYHA class 3. Her history also includes hypertension, COPD. She's got a AAA, which has been stable so far. It measures about 4 centimeters. No major prior surgeries. Next. Vitals are stable, as you can see, except for mild hypertension. Her physical exam also is essentially unremarkable, except for the murmur, which is consistent with her severe AS. Next. So her STS score is 3.2, which puts her in the moderate range. Her labs are essentially unremarkable as well. You can see her renal function is normal. Next. And then her EKG, which is important, as this is very important. We factor into our pre-procedural planning as to whether or not we're going to leave the temp wire in or out. You can see she's got normal sinus rhythm, and her QRS is pretty much very narrow. Next. She had a pre-procedure cardiac cath, which essentially shows very mild to moderate circ LAD disease and mild to moderate proximate RCA disease. Next. And then her echo, she has a very calcified aortic valve, as you can see. Her mean gradient was 52 with a peak of 100. Her valve area was 0.6. Next. And the short axis of the aortic valve is not, you can't really appreciate the morphology of the valve, but you'll see that better with the CT. Next. So her CAT scan or CTA for the procedure, you can see she's got fairly non-calcified CFA, and this is very important too, as to which would be the primary access and not. The next slide. Same with this. You can see our primary access here is the right, and she's got very mild calcification and low bifurcation. Next. Now her CT shows, as you can see, that she's got a bicuspid aortic valve, Siever's type 1 with a fusion of the right and left cusp. You can see the raphe, and you can see the calcification at the leaflets. Next. In terms of measurements, the annulus is about 73.6 perimeter, diameter is about 22 with an area of about 4.1, and the commissures are 65, 18.6, and an area of 2.7. Next. And same for the sinus of Valsalva. It's pretty big, 35, 30, and I think 31. And you can see the coronary heights also very favorable, 13.7 next, and 12.6 for the right and left, respectively. And her STJ is about 28.6 and 27.9. Next. So the big questions here, which we will be talking about.
Yeah, we're going to stop a little bit, Chinedu. Sorry, thank you for presenting the case. I appreciate it. So the great question, there are several questions. Can we go back to the slides, please? So there are great questions here that we have to discuss. We'd like to discuss with the panel here. One of them would be the sizing. How we're going to size the valve? Are we going to be based the measurements on the annular measurements or the commissure perimeter or area? This is question number one. I'd like to hear the panel comment on that, please.
Great question.
Can you show up the annular and commissure measurements again on your slides?
Sure, please
can
go
take a look
back
on that.
to slides, please. One more. Another one. Yes. As you can see, this would be significant because the annulus, if we size by the annulus, if we're planning on using a self-expandable valve, we would go with a 29 valve. But if we size based on the commissure, we would be using a 26 valve.
What's the long axis measurement on that commissure?
You're talking about diameter?
Yeah, it looks like the average diameter is 18.6, but you're asking about what the major axis is, Adam?
Yeah, so major,
Yeah.
major minor axis on that commissure.
Yeah.
Is it in the 30s?
Yeah, we didn't measure there, Adam, because normally we don't size that based on that diameter specifically. So I don't know what that measurement is. We don't use that as our normal, regular way of sizing the valve.
Well, this is a good question. So how many of you would want to size this based on the commissure? I mean, it's bicuspid, and I know that's why they're asking, because, the parting IFU says size it based on the annulus, but I know a lot of us have drifted more towards sizing in the commissure when it's a bicuspid,
Or sizing by whichever is smaller, right?
whichever is smaller.
That's what some people would suggest. So in this case, the commissural measurements would suggest you could get away with something a little smaller. Is that true?
Yeah, it looks like it would be a 26 versus a 29 evolute.
And he asked the next question, which was depth, right? So if we're going by commissural sizing, would you implant, how much higher would you say
That
from
is
your
correct.
side?
So
Yeah.
if you go back to the slides, please. Can you go back to my go back forward on the slide? Another one. That's going to be so. Before we talk about the depth of implantation, which definitely is a very important piece to discuss, I like the comments on the panel as well on which type of valve, balloon expandable versus non-balloon expandable, self-expandable or either with evolute or now that we have the approval of Lotus. What would you guys pick here? Is there and the specific reasons for that? Can you shed some light on that, please?
Who wants to comment, Molly?
Well, for us, we would use balloon expandable mainly because that's what we're more comfortable with, and the data. Well, I will. Wait, hold on. And I will say that. But if we were going to do this, we would use a balloon expandable valve. Raj Makar's data shows that it's safe and effective to use the balloon expandable valves, with the only caveat being if there's a lot of leaflet calcification and raphe calcification, then those have a higher risk of rupture. But what Paul was alluding to is that we at our program probably would send this to surgery because it's bicuspid, it's a lower risk patient, and it's kind of a small sizing anyway. So we would probably not do it until we get more data from from all the bicuspid registries.
Great. I think it's a great comment. If you go back, can you go back to the measurement slide? Because you mentioned about the balloon expandable valve. Can you show? Yeah. So go back one more. Yeah. So there. So if you would go then use a balloon expandable valve here, which valve would you pick? If we're considering that this is a lower risk patient, right? Therefore, we want to provide her the very best hemodynamics, right? If you look into the area, if you size by the commissure of 272, or even sizing, if you're going to size by the annulus, right? By the annulus, you would go with a 23 millimeter sapien valve, and if you're going to size by the commissure, it's going to be an even smaller valve, right? So does that play a role in your decision-making process there or not?
I think this could be one of the, we've had a bit of success using self-expandable valves in this territory, and, your center is kind of one of the leading pioneers of using Medtronic core valve. I'm actually more interested to see from a Lotus perspective how this would work in the very heavily calcified bicuspids. So
Right.
I don't have enough experience off the top to tell exactly what size Lotus would be used here, but from a coronary access standpoint, from a repositionability and predictability standpoint, I think that you'd get, this would be very interesting for us in the next upcoming years.
I like,
All right,
I
great.
like the idea of a Lotus because of the risk of PVL. Molly, you want to talk about size?
Yeah, so Lotus would be great, except it's not a high-risk patient, so you can't use Lotus. But if you could, then, I mean, we tend to size actually from the annulus, and we would use it, that would be a 25 Lotus if you use the annulus dimensions. But again, it's a intermediate risk patient at the most, so it doesn't meet.
We have
All right, can you
Alan
go back?
Zaharias here in the audience. I can see him through the bright lights. Alan, what would you do? Bicuspid aortic valve? Would you do self-expanding, balloon expandable? And how would you size it? Annular or at the commissure area?
I think the level of calcification is incredibly important. I think whether or not your raphe is heavily calcified and whether or not the calcification goes down into the LVOT. And I'm a firm believer of the concept of you will only seal at your smallest dimension. And there's a convergent and divergent annuli, and I think that's where you need to make sure you get your measurements. 4 millimeters above the annular plane, 4 millimeters at the annular plane, 4 millimeters underneath the annular plane, and then you come up with either an inverted parallelogram or the trapezoid or a regular trapezoid. If you can go back to your slide for the sinus measurements or the commissural measurement.
Go back to the slide, please. Back one more.
You want the commissure measurement?
No,
here,
actually,
Alan?
maybe the next one.
Yeah, this one. Yeah.
So that area that is traced, I think it's a little bit of a subjective area, right, on the panel of the right. I think we all are in agreement where the panel on the left is, what the true area is. I think it's much more useful to know what the diameters are, both parallel to the opening of the valve and also in the longer axis. And I think that could give you a better understanding of what valve size you would use.
Okay, let me ask another question to the panel there, because there are people still doing. Is there a role for balloon sizing here? Does anybody use still balloon sizing in bicuspid valves or not?
You're getting a lot of no's,
No.
Guy. Is that what you're planning on doing?
We are a no as well, so that's fine.
Okay, yeah.
We're good with that.
The only reason I brought up the long axis measurement on that commissure is sometimes if the valve is very eccentric, and let's say that measurement is 30, and you're going to put a 26 in, and it doesn't circularize all the way, you might predict a leak. And so sometimes I check that one measurement to help me determine size. That's all.
Okay, I think those are very good points. So let's show our last slide, please. Okay, so the plan for the case then today is going to be, as you can see, we're in the cath lab here. So cath lab, transfemoral TAVR, local anesthesia with minimum sedation. Really, our patient is awake and interacting with us. We've been doing this since 2013 and works extremely well. Commissure perimeter sizing, Evolut Pro 26. We had planned to go sheetless initially, but because of the AAA, we switched our strategy. We just put a 20 French sheet there. Obviously, we're going to aim at a shallow implantation and post dilatation if suboptimal gradients or significant PVL. In fact, I have another question for the panel. Is there anyone who is doing routine post-dilatation for bicuspid? Because some people are advocating that we should routinely post-dilate regardless of PVL and gradients. I'd like to hear the comments of the panel there as well, please.
I would just say that we're not routinely post-dilating. We are routinely pre-dilating. And I might use something a little bit more aggressive than an 18. I might use a 20, but I probably wouldn't use a true if I were going with a 20.
So maybe like a V8 balloon or a
like a
ZMAD
ZMAD or
or something?
something,
Yeah, a little lower atmospheres. Mm-hmm. Doesn't sound like anybody's routinely post-dilating. Chris, what do you think?
Well, I wouldn't do a core valve here, mainly because we're on the partner trials. But I think there's one more consideration here. The study that Molly quoted with the S3 and the TBTR data seemed to show a higher risk of stroke at 30 days. It goes away by 1 year. But what does the site think about and the panel think about cerebral embolic protection for this case?
So we don't use cerebral embolic protection here. We don't think that our rates of stroke are 0.5%. I don't think that we have data, right, clinical benefit of cerebral embolic protection. This is routinely we don't use for any patient here. I know that this is a very controversial topic, right? Some clinical benefits showing from the German series, some surrogate endpoints from our colleagues in the Cleveland Clinic data, but we don't use cerebral protection device for any patient here.
Looks like a good plan. Looks like a good plan.
Okay, so we're gonna move forward then. Okay, so let's flush this guy. All right, so we're gonna move with our pigtail up.
Have a so update them with what we've done so far.
Say it again?
Want to update them with what we've done so far.
All right, so we have a long sheet on the left side. We wanted to bypass that AAA there. So we have a long arrow sheet there.
Guilherme, do you want to tell us a little bit about your location of your pacer in terms of IJ versus femoral, in terms of,
Absolutely, yeah,
and
that's a very
also
good question.
whether you use any of these? There's other specialty pacer products. How have you used these in your practice? When do you decide what to do?
Thanks for the question. That's a very good question, actually. Well, we do pacer always in the jugular vein, and the reason for this is because, as you know, we do all of our cases in local anesthesia. So we want the patient mobilized 5 hours post-procedure in the CICU. And if we have to keep the pacer until next morning for any conduction disturbances we have, then we want to be sure that the patient is going to be able to mobilize. So that is the reason why we do jugular vein pacer. In addition to that, I think that's a very appropriate question. We're dealing here with a moderate surgical risk patient, therefore we want to minimize the chance of pacer. Our rates are actually very low here. We have like 6% pacemaker rates. Ready? Cine. I'm gonna take a picture quickly here. I'm gonna keep. All right, excellent. All right, so there we got our initial picture. And this is just we're gonna locate where the right coronary cusp is, which is right in the center. Even if the right coronary cusp was not in the center, we would not take an additional picture here. We use LAO, actually the LAO technique for evolute implantation. We helped develop this technique, right? So we consistently use the LAO technique, and we tend to implant our valves really in shallower positions. Although the formal recommendation of Medtronic is to implant this device from like 3 to 5 millimeters deep. I'm not talking about a bicuspid, but generally speaking, right? Well, we do tend to implant our valves really in shallower positions because not only delivers better hemodynamics, better oversizing, but also minimize pacemaker implantation, right?
Guy, I completely agree with that. And I love that technique you're describing of going a little bit LAO, the pro technique. It really saves a lot of angst, and I think it really helps minimize the death, and I actually think it's being underutilized.
Yeah, I agree with you. And let me say, I think one important thing for us when we, educate our fellows and, less experienced center, you cross, is that we have to try to keep the procedure reproducible, simple, and the LAO technique really delivers that, really delivers reproducibility to the intervention, and that is basically what we follow. I know that some people are doing the cusp overlap technique with RAO, that Hamal, my friend Hamal, has demonstrated great results with that, but we don't do it. We use the LAO technique. We're a little biased,
I don't think there's
right?
a
Because
yes. It took 1 second for you to cross that.
It's because I'm a surgeon.
So Chris is a surgeon. So Chris actually is from Chile, so he uses the Chilean technique to cross the valve. He doesn't disclose to anyone.
That was really impressive.
So basically, as you could see, the way we cross the valve, we avoid going and pushing the wire. We always look for the jet, right? The crossing of the valve has to be something elegant, and we always look for the jet to then be able to cross the valve. We never go with the straight wire and keep pushing and the wire goes in the left main, goes to the RCA. We always do a very gentle crossing of the valve there. All right, this looks good.
Yeah.
Okay, so we're in the LV there. We usually use the AR1 catheter to cross the valve. Maria, we have a cable in front of us. I don't know where this cable is coming from. Can you please help us on that?
Guilherme, while you're working, you want to tell us a little bit about your wire selection, when to use a pigtail, Confida wire, Safari, pads, those
absolutely,
things.
absolutely. Another thing that we do before we talk about the wire selection, I think we kind of established a way of performing our procedure, a consistency. That's the word that I love to say to the fellows and to everyone, to all of our courses of optimal practices that we have here. We're going to flush the large bore sheet in between every exchange. We're really meticulous about everything that we do. I'm very sure that by doing so, being meticulous and having like a airline checklist type of procedure, it's still there.
The wire?
You have the wire, Phil? Okay. Anyway, go back to your question of wire selection, right? So to go up with the sheath, with the 20 French sheath, we use the supracore wire. The reason why we like the supracore is because it has a very floppy tip. I'm sure that most of you guys have used that. And it has a strong body, just like kind of a extra stiff wire. So we go with our sheath over that, right? And then for the valve itself, we use 100% Safari. We are very comfortable with the utilization of the Safari. Even in like horizontal aortas, we use Safari for every single patient actually. It's a very safe wire, as you know, right? And delivers a lot of control in the procedure. So we are very comfortable. Can you change the colors?
I completely agree with you, Guy. It's amazing, you know, the Safari wire was developed actually to facilitate the Lotus valve, which wasn't commercially improved until this year. But the Safari wire has been used, and I use it for every chamber in the heart, anytime I need large bore delivery, and it's been available for years now, and I completely agree. I like the stiffness more than the Confida wire. I don't know, do people use Safaris?
Yeah, you know, what I like about the Safari wire is actually the actual, you know, tip of the wire, the shape of that tip. I think it remains more consistently. Sometimes the Confida, what I see is when we advance the Confida, it loses that, you know, shape. So that's why I prefer to use the Safari, but the Confida is a great wire as well. This is just I always say that there's no better wire. The best wire is the one that you're more comfortable with, and the one that you're gonna know the response of the wire when you push it, when you pull it. So that's the best wire. So.
And do you have a sense as to when you use a smaller, when you use a larger Safari from your side?
We only use the extra small. Are you good? Let's see.
Okay.
We only use the extra small for every patient. It's still there, but it's okay actually, Maria. Don't worry. Yeah.
Okay.
So can we get the LVDP, please? So guys, another important piece to discuss here. We always do hemodynamics pre and post. As we talked about, we don't have transesophageal echo in place, so we only do TTE, right? So we do the hemodynamics pre and post to understand what the LVDP was, and then we do the echo. If they are concordant in the end of the procedure, if there's no significant increase in the ADP, and the echo does not show significant PVL, we're gonna be happy, right? If there is a discordant, if we get discordant information, then we're gonna do aortogram. You're gonna see we don't do aortogram. We don't take picture in the end in the peripheral vessels. The aim is to finish this procedure with 35, 40 cc's of contrast in local anesthesia in the cath lab, and that's basically it. We try to minimize progressively the resource utilization here at the hospital. As you can see, we don't have the anesthesia team with us. Who's giving the sedations are our nurses basically here in the cath lab, and it works extremely well.
You want to look at the valve?
Yeah, let's check the
We're
valve.
going to pre-deal, right?
Yeah. So we're going to check the valve right now, make sure that Chris did a good job here.
Okay.
1 second. Seen it? All right.
Looks good to me.
Looking good.
Okay.
Chris, so we always check the valve, obviously, before we pre-deal, right, in case we have
Get the
any
Safari ready to
issues
go.
with pre-dilatation and severe. Guys, did we get another ACT? 370? We're good? Perfect. Okay, any further comments from the panel before we advance our Safari and go pre-dilatation?
I have one quick question for Adam. So Adam, you're the Basilica King. Basilica native leaflets, bicuspid? What do you think?
Sure. So basilica certainly can be done in native leaflets for coronary obstruction, and it has been done in about a third of the cases.
2 Kellys.
There
we have
was a
another Kelly,
bicuspid
please?
patient who had a risk of coronary obstruction,
One more,
and so
Kelly.
we did do it for coronary
Just one
obstruction, but as proof of concept, it did seem to circularize the
Kelly,
valve
please.
more on follow-up CT. But just so you know, you cannot burn through calcium, and you cannot really split the raphe. That's not what you're trying to do. You'd actually be splitting healthy leaflet next to it to try and help circularize something, you know.
So do you think that if we had I want to say easy basilica technique, would it be something we would routinely do for bicuspids to improve the TAVR performance?
The hypothesis has been raised, but I don't think we have any data to support that yet. But it's an interesting concept. I mean, if you believe that the goal here is to get a
We're almost there, Marlene. We're working on you.
You know, if you believe that a more circular valve will be
cannot,
better for
Marlene.
durability,
Sorry.
then it might allow that. But remember, you're splitting leaflets, you're not changing the annulus. And so if you believe that it's the leaflets in themselves that are not allowing the circularity, then maybe. But we're not modifying the annulus, right? So.
You pulled that cable now, Maria. You're being, you did, yeah. But not all the way. You just pulled it like partially. Do it again because you're in the right. All right.
There you
All right,
go.
guys. So our Safari wire is in the LV there.
Okay.
We got a good ACT. Our valve is ready. So we're gonna move forward with our. So the discussion about which balloon to use, right? We only use true dilatation balloons here. We don't use semi-compliant balloon. And then the reason why is because, number one, the true deal goes up and down quickly for patients with poor ejection fraction. It doesn't watermelon seed normally, very often. Sometimes in bicuspid valves, yes, but normally it doesn't. Hopefully it doesn't today. And we are very conservative. Predilatation should be a very conservative step of the procedure, right? And we pre-deal, of course, all of our bicuspids. We pre-deal patients who have more than moderate calcium in the leaflets, or if the patients have uneven distribution of calcium, because we observe with our experience over time that if the distribution is uneven, the patient has a significant chunk in one of the leaflets and the others are not heavily calcified, the valve is going to expand obviously towards the weak part of the valve, and we're going to have paravalvular leak. So that's, in addition, when we have significant or critical aortic stenosis, aortic valve error less than 0.6, we pre-deal all the time, because obviously we don't want to go with the valve and then the blood pressure drops immediately. We have to go fast. The goal here is to do a very slow implantation, and predilatation helps very much. In addition to that, by doing so,
Yes, I have
Flora?
the wire.
don't let the arm move. By doing so, we reduce the likelihood for post-dilatation. We post-dilate very rarely here, like less than 5% of our cases. Really, really rare to post-dilate. Okay, so let the wire go now. 1 second, please stop, please. All right, so we're moving forward here with our, one second. All right, so we're gonna go now and pre-deal.
You ready?
I have the right. Who's gonna pace? Here, okay, good. Yes. Go, Chris. Stop. Good. All right, so we are across the valve there with our true deal, 18 millimeter, again, very conservative. You guys ready? Ready, sir. Okay, pacemaker on at 180.
Pacemaker's on at 180, sir.
Pacer up.
Pacer's up, back up to 50.
Okay, total. Good, blood pressure is coming back. So I think one important aspect today, before this live case transmission, we had optimal practices course here, and we were discussing with the teams that came here. By doing these cases in the cath lab in local anesthesia with basically minimum sedation, right? Half of our patients get actually zero sedation. It enables us to have much more control, although it seems that it's the other way around, right? But it's not. So it enables us to have much more control. We almost never have to use, pressors or inotropes. So even patients with poor ejection fraction and critical AS, they tolerate quite well.
So, Guy, I have to ask you, what do you mean by zero sedation? Is that like no fentanyl, no Versed, no propofol?
Nothing. Zero sedation means local anesthesia only.
Just local, just lidocaine.
Just 2% lidocaine.
Just lidocaine, that's correct.
Lidocaine, no fentanyl, no Versed?
No Versat, no fentanyl. Fluoro? 1 second, guys, 1 second, 1 second. 1 second.
yes,
We have to watch that because we're
I
right above
give
that.
that for my PCIs. Maybe I should stop.
Yeah, we do this. We do the same. We only if they ask for it. I mean, otherwise they'll just get local. Yeah.
Just local?
I mean, that's the true minimalist
Really?
TAVR. Right?
Am I like old here? How many people do just local for their PCIs or procedures? Okay, you got one
Yeah.
in the audience. So you and Adam and Guy?
Stop.
The rest?
Guys, can you move the screen a little south
No?
for us, please? Adam, I have a question for you. So how often do you guys do no sedation there in Emory?
I don't have the exact statistics, but there was a period of time. I've only been there a year, but there was a period of time where 80 to 90% were no sedation at all.
You mean just
Yeah.
local?
Yeah.
Yeah, that's great.
And,
yeah, that
and
we,
they,
yeah,
you know, the sort of, I mean, Emory was sort of early on adopter in that, and it had a lot to do with, you know, when you sedate the elderly, they're actually just better off if you just talk
We're
to
almost
them.
there,
We do,
Marlene. I'm almost
we do
there.
minimalist TAVR, but we usually give
still
half a
give a little
milligram of
bit,
Versed
yeah.
and 50 of fentanyl, something like that.
Even
you
in
know.
the 95-year-old.
I mean, it's comfortable with the, you know, it's what we do for PCI.
Have it.
But I'm
Right.
very provoked by this. I think
LAO?
we're gonna try this.
make sure. So we're moving forward here with the valve, going LAO, make sure there's no separation of the nose cone and the capsule. Okay, stop.
Okay.
Now, we're gonna come back to our initial projection of REO and Caldo. Guys, we're gonna pace at 130 when appropriate, okay? We have to push the pigtail to the bottom of the nose. It's actually tangled, Chris. Pull back all the way and then go, yeah. Almost done, Marlene. Are you okay there, darling?
Okay, that's better.
Awesome,
You
perfect.
got a micropuff there?
Photo there? Are you in the bottom?
Looks like it.
You're not.
No.
Push a little bit. You see, you're a little tangled
Okay,
still.
yeah,
Try
yeah,
to
yeah.
rotate your... All right, so we're gonna, of course, oh yes, perfect. So
Okay.
that pigtail is our landmark there. We're gonna move forward with the valve now. Hold the wire, please, Chinadu. Okay, Chris, I got you. All right, guys, so now, push a little more, stop. Puff there. All right, push a little bit,
Yeah.
the pigtail down. Puff, stop there.
Not at the quite bottom.
Puff. Good. I mean, we're at the very.
Yeah.
Just trying to position the pigtail in the very bottom of the non-chronic cusp there.
We really need smaller pigtails, don't we? It's too
Sometimes
big.
we do. So we have to move a little quickly here. Her blood pressure is a little down. So I'm going LAO. I want you to observe what we're doing now. Taking the parallax out, going LAO. Okay? And going a little bit of caldo. So there's no parallax anymore. Hold the wire. Chindu. Advance the valve, Chris.
Okay, I'm coming.
Micro puff.
Okay.
There's not in the bottom yet. All right. Okay, we're gonna start. I think it's a good starting point here. Let's leave the wire. So we can move quickly at this point because the valve is fully sheeted. Now bring the valve back, please. Bring back a little bit. Puff. Good. A little more.
What depth are you going for, Guy? Are you going for 0.2? Well, how deep?
Yeah, we're gonna try to go shallow. We're gonna aim at like from 0 to 2 is more than, even if we go negative, we're gonna deploy here.
Yeah.
Puff.
Yeah, that's 0.
Start pacemaker at 130.
Pacing at 130.
Micro puff, feel.
Like it.
Pace. Pace at 130 there. Pace at 140.
Going up to 140.
Pacemaker off.
Pacemakers off, back up to 50.
All right, so we have parallax there. We're gonna come a little caldo. Try to take parallax out. Okay, let's do a quick cine here. Cine. Inject. All right. So, now I have a question for the panel. Deploy or recapture?
So you're getting a couple of votes for recapture. I think we have some concerns. I think the non-coronary cusp, you guys agree?
Yeah, the non-coronary cusp, we're negative there.
Yeah, you may be
Probably
negative more than
minus
2 or so.
2?
Yeah, that's exactly what I was just thinking.
Yeah. So if the panel allows me, I'm going to deploy.
What's your pressure, Guy? What's
The
your
blood pressure is 100. Can you show the hemodynamics of the patient, please, guys?
Okay. And then can you lean into it? Will it change if you lean into it at all?
Can you see the hemodynamics on the screen?
Yeah, we see the hemos. Yeah.
All right, so now, again, the discussion is the commissure sealing, right? If we believe that we're sealing the commissure, then that's the depth that we need, right? Because we're not sealing the annulus, right?
Sure. I mean,
All
your
right.
commissural annulus was, your commissural diameter was much smaller. So you will seal by the leaflets by themselves.
Yeah. Okay, so let's deploy. Fluoro. So I'm going to pull. So I'm going to put the wire all the way inside the nose cone. As you can see, there's no wire left behind the LV. And the reason is because we want to take the tension out of the system, totally, right? The second step is, as you can see, Chris is giving a forward tension here, gentle forward tension. And I am very, very slowly deploying this device, right? And the reason why I'm saying very, very slowly is because we want the device to lock in place. We don't want the device to have any issues and pop up or anything like that. So as you can see, the formal recommendation of Medtronic is to deploy one hook at a time. So what we want to do here is to when the top of the valve starts to come out, I'm going to stop. And then, you see that what I'm doing? I'm just letting the valve sit and adapt to the annulus there, okay? So now I keep going very slowly and gently, and Chris is giving a gentle forward tension. So one thing that is reassuring is I look at her hemodynamics. So she has 160.
Are you going to pull the pigtail now?
No.
No, we don't.
We don't pull the pigtail now. We're going to pull in the end. Keep going, Chris. Gentle forward tension, forward tension.
Yeah.
Wow.
All right.
Looks like you're fully released.
Yeah.
It is. And we're going to come back very, very carefully here now.
So you pull the nose cone through without the wire.
Yes,
Yeah.
without wire. We don't leave any wire behind. And then we're going to, the reason why we don't leave the wire behind is because there's no clinical value to do that, right? So that's why I don't. All right. Okay, echo, please.
Some of us like to
Marlene,
get
are you
hemos
okay?
afterwards.
Are you okay, darling? Can you show the hemodynamics of the patient, please? Thank you. Okay, ready for echo. Almost, we believe we are done, Marlene. We hope we are done, okay? We can take this out. Let's put the suprachorion. We can take this out. I have the sheet.
So Guy, without the wire in the LV, you're going to rely on echo for all of your aortic valve hemodynamics, or are you going to recross?
No, we're going to cross. We're going to go
valve
back
again,
to the LV now with the pigtail that we just pulled out. We're going to go back to the LV, of course, and then... Fluoro there, please. Quick fluoro. Just 1 second.
Do
Steve,
you
let me
take a
just
picture here from the pigtail before you remove it from the non-coronary cusp?
No, I don't. I took a picture. I did take a picture just
No, but
before we
after
deployed, but
deployment.
after that, we don't.
You don't take
Okay,
another
Phil.
one here?
Yeah. Help me
Be
there.
interesting
Just
to
1
see
second.
where the
Is it coming out?
struts are compared to the non-coronary cusp.
I often don't. I usually go with just the
Okay. All right, we're good.
Just in this case, because they're high, it'd be kind of interesting to show. I'm not talking normally, but it'd be interesting to see what it is.
So another thing important, guys, and Adam can comment on that, obviously, is the fact that we have consistently the echo team that works with us. They know exactly what we're looking for. He's going to look for effusion immediately. The first thing he's going to look into. He knows the views that he's going to get, right? And
Don't see any significant effusion.
good. You can comment, Steve. They can hear you.
Don't see any PL just yet. Pretty good.
No change. Good. Okay, are you guys, are they seeing the echo there?
The one thing that I have when I think about deploying high, and I'd be curious to see what others think, is that if I have a reasonable concern that I'm going to have to post-dilate, then I don't implant high because I worry that it'll pop out further. I mean, does anybody else think about that?
Minimum. That looks great so far.
Yeah, Andrew?
Okay,
I
show me
totally
the
think
three
that, and
chamber.
I think it'll shorten a little bit as you do post-dilating, and if you're already starting high, you run the risk.
Marlene, we're almost done, darling, okay?
I'd be incredibly careful with my pacing run and
Right.
really make sure the balloon is completely deflated before turning the pacer off.
Right.
But I think you still run the risk.
How much AI are you going to call this on this echo? I mean,
Oh,
the
that's
diastolic
definitely
is
mild
73,
AI.
so
That's
it looks mild.
definitely mild. And we're gonna do hemodynamics right now.
Okay.
And we're gonna obviously check the gradients to see if we need to do anything else, which I doubt, but we'll see. Mean gradient of 9.
Wow.
So now we're gonna cross the valve. Before we cross the valve, panel, happiness or frustration?
I think we're all quite impressed with the depth of implant you got there.
Good, excellent. All right, so we're gonna do now our final hemodynamics. And our, Marlene, we're almost done, darling, okay? Okay, are you feeling okay? Okay, so Marlene is great.
Would you be willing to do a rotational, angio for us, just to see how circular the valve is?
That's a very good point. My question is the following now. If we do that, we have mild PVL that with the expansion of the valve, that's going to come down to trivial probably tomorrow. Then if the LVDP is stable or reduced, right? If we do the rotational and there is an underexpansion, what should be my reaction? Because so the question is, if I'm not going to react to the information, then I'm not going to do it.
Well,
right?
I would actually, I see your point, right? I wouldn't post-dilate this valve or do anything different to it. I think for us, we're just more curious to see where exactly the deformation is for the long-term durability. If it's happening at the annular level, that's different. If it's happening at the bottom, it's
So
different.
you would leave a mean gradient of 9?
I think 9's a little high for a 26.
Because tomorrow it's going to be 16.
Yeah. But I agree with you
Molly.
that you might not react to it, although what we don't know because we don't have a ton of data. But remember, the valve is only slightly superannular, right? The leaflets. And so if you're pretty eccentric right beneath it, the leaflets may not be perfectly symmetrical, and that may affect durability long term.
Yeah,
right?
I think it's a very good point. We don't know the answer for that, but it's a very good point. Eventually, years from now, we're going to start post-dilating routinely bicuspid valves. In fact, that was one of the points that I brought up in the beginning of the discussion here, right? If we're routinely post-dilating or not. And I think the durability question is a very important one. We don't know exactly how to proceed here, but anyway. Okay, so you want to take a look at the valve. Let's see their fluid there, Chris. Let's see if I can.
I do wonder about that gradient of 9, though, because I think with evolutes, I really think we should be in the low single digits. And when it's in the high single digits, I get a little concerned that it's not quite expanded as it could be. I mean,
Well,
does anybody else have that concern? Or what do you guys
My
think?
gut looking at this is just from evolutes, and bicuspids are different. 9 is, yes, it's on the higher side, but I don't think it's going to be 16 tomorrow. I think it's going to be in the 11, 12 range max, and it's going to stay in the same place for the next month. Alan, what do you think?
agree.
You're about to say something.
So she's not sedated, right? Normally, if you give fentanyl or general anesthetic or things of that nature, that'll definitely cause a lower gradient, and then tomorrow when she's awake, that may be higher.
Completely awake.
So if she's awake,
the
this
easier
may
thing,
be more realistic.
The easier thing now would be actually give fentanyl and Versed instead of post.
100%.
Totally awake.
So Joel's in the back. Joel, tell us what does a CT scan look like on these valves and because we routinely do CT scans on all of our patients. For a bicuspid, are we going to expect things circular, or is there going to be deformation of the leaflets? How's it going to look?
Yeah, it's likely to have some asymmetry, as the sealing seems to be, the anchoring seems to be at the commissures there, and that's what Adam was mentioning about during the the rotational angiography. But we need to see where exactly. I'll be very curious with the CT where the leaflets fall within the anchoring point, because and there seems to be some AI, but it's paravalvular, it's not valvular. So definitely somebody that we would need to take a look at 30 days.
All right, so now I'm going to do quick hemodynamics here, as we always do for every patient. Okay, let's do a 0, guys, please. 1 second. Okay, 00. Double 0, please. Doppio 0. 0 again. All right, zeroed. Okay. There we go. All right, let's go and do our LVDP, please. Yes, showing. EDP. So the EDP is essentially unchanged from the beginning, right? It's actually, if anything, it came down. Actually, can we give 250 of fluids, please? If anything, the EDP actually came down. So considering the echo, which you're happy with, coupled with the great hemodynamics, right? I think we are satisfied with our results. I think we're very happy, actually. Our patient is doing great. She's awake. She's interacting with us. Any further comments from the panel here?
Guy, that was fantastic. What was the gradient there for LVA? What was your mean gradient?
The mean gradient was 9.
9 on the echo or on the cath?
No, on the echo. We don't. The gradient is actually virtually.
It looks even less on your cath. That's why I'm asking.
Yeah, it's less. It's even less. Yeah.
Do you typically take a final angio, or do you just go by echo for contrast?
That's a very good point. Now, the reason why we don't take the final angio is because we have good echo results. We have good hemodynamics. When they are concordant, no angio. If there is a discordance between the results of the echo and the ADP, for example, if the echo, the PVL is mild or none or low, and then we have a significant increase in the ADP, definitely we would do angio. But because that's not the case, they're concordant, we do not do a final angio. We do not take a final picture in the peripheral vessels either. If the pulses are good, we're done, right? We minimize the utilization of contrast, and it works quite well. So every time I'm not going to react to an information, such as the orthogram, we don't do it.
Well, how about your pacer? What is your plan for your pacer? It looks like you may have a little bit of bundle branch on
Yeah, that is correct. Yeah, so we're going to keep the temporary pacer until tomorrow. And I am assuming she did have left bundle actually after we pre-dilated the valve.
Yeah.
I can almost guarantee that tomorrow morning this is going to be gone because it's very shallow implantation, so I doubt that that's going to be there. But so I'm going to keep the temporary pacer until tomorrow.
So is it a balloon tip pacer you leave in, or do you switch it to a fixation?
Yes, it's a balloon tip pacing, yep. Mm-hmm.
Questions or comments from the audience? Anybody?
Can you adjust my mask here, please? Somebody? Almost.
Are you going to show us your face, Guy? Fantastic.
He's coming back.
Questions, comments? Nothing?
If I do that here, I'm not going to be JCO compliant, so I'm not.
We were wondering your lack of goggles. You don't have safety goggles on. Obviously, you're very confident in your blood management.
You know the reason why I'm going to be very honest is because this mask, when I put my goggles, they get foggy all the time. And I didn't want to start like putting, tape here and everything and asking them to adjust during the case. So that's the reason why. But normally I use them.
So, Guy, another thing about your management for this patient. So you're going to take the pacer out tomorrow. You're going to send the patient home tomorrow as well, is the plan?
Yeah, so we send 85% of our patients home next day before noon. So that's the goal. Discharge before noon next day. So that's what we're going to do.
Do you have a post-procedural care protocol for ambulation as well from here?
Yeah, so the ambulation, as we talked in the beginning, the reason why we have the pacer in the neck is because we want to mobilize these patients early on. So 5 hours post-procedure, these patients should be mobilized and out of bed and, being able to at least get out of bed and sit in a chair. So we are, and in addition to that, what we have done here To manage these patients post-procedure, we have our own structural heart service. This made a huge difference because the management of the patient is much easier, right? We know the patients, all of them by heart, obviously, right? So the management is easier. When we send them home, the instructions that we provide to the patient, everything is better. We noticed that reduced significantly our rates of readmission. So we do that. So tomorrow, I'm going to round on these patients. They still go to the CICU because of the hospital policy. I believe that there are a lot of patients they could go to a step-down unit. There's no question about it. But she's going to go to the CI, and then she's going to be discharged from the CI home tomorrow morning. I'll pass by tomorrow morning. I'll see her with my fellow and send her home, hopefully home.
Fantastic. Great. Questions, comments? Any questions from the audience? Questions? Fantastic. Well, Guy, that was absolutely fantastic. I think you demonstrated a lot of expertise, especially the high implant. I think that would make a lot of us a little uneasy, but you showed how it can be done very safely and effectively with great results. So thank you very much, Guy. Congratulations.
Thank you very much for the opportunity.
Yeah.
Thank you, everyone.
Fantastic.